It's, you know. Oh,
Hi.
we've started well. We've started early, so welcome everybody to our lunchtime session here on a rather grey day in London. My name is Patriic Gayle. I'm with the Gay Men's Health Collective that provides harm reduction information within the context of Chemsex. We have a health and well-being website, and we make films for the LGBT community. And this is very literally a fireside chat. And I'd like to hand you over to Leila.
Thank you, Patrick. Hi everyone, I'm Leila Reid. I work for the Hepatitis C Trust. We're a national charity working across the UK to address hepatitis C and support people through hepatitis C treatment. So we're a peer-led, mostly peer-run organisation working nationally in England.
We look to Bob.
Yeah, Bob Hodgson. I'm an independent advisor with the Metropolitan Police Service, not a policeman. We're essentially members of the community who advise and challenge the police in their day-to-day business. I'm part of the Met Police LGBT Plus Independent Advisory Group. We look at hate crime, we deal with LGBT related homicides, and more recently some of the issues concerning use of drugs and chemsex, which is causing an issue in the community and for police and ambulance services.
And just to be absolutely clear, you ain't a copper.
I'm not a policeman, no. Am I wearing a blue shirt?
No.
Were you, did you, so we were just looking, well, at the report that you did for the Met on the review of GHB deaths, and we wondered whether you would like to kind of start off by telling us a little bit about that.
You were on the panel at the review of GHB deaths, and you were on it a few years ago.
Yeah, it was quite recently. The Met, this all started with the use of GHB as a weapon, essentially, in what has become a quite notorious serial killer murder sequence. Basically, 4 young men were found dead with what apparently looked like drug overdoses, but it turned out that they'd in fact been enticed, if you like, or met up with the killer, who thankfully now is in jail, and he had used GHB and injected them with so much GHB that they died. These are the 4 which resulted in deaths, but the same person, I'll name him, Stephen Port, who's now in jail for life, also drugged and assaulted a lot more other people. So it was really the first use of GHB as a weapon in that case. It's fair to say that the investigation into those deaths was handled appallingly by the police. I think they now admit that, and as a result, the advisory group tasked the Met Police with looking around any other GHB related deaths to see whether they had been part of the same criminal action or were suspicious in any other way. So the Met Police spent a lot of time, trawled all their databases. They turned up 58 other cases where people had died as a result of GHB poisoning, and they reanalyzed each of those deaths in detail.
And you were on that panel?
And you were involved in it?
Yes, we were on, having had the investigators reinvestigate the deaths.
Yeah.
I was then on a panel which looked at each of the cases individually to see if they were a murder or anything else like that. It turned out, thankfully, that none of those 58 cases that we turned up had in fact been as a result of someone deliberately trying to do harm, but nevertheless, the number of them and the circumstances were extremely tragic and harrowing.
I think you told me that you just found this process yourself very harrowing.
Yeah, it was. I mean, a lot of these deaths happened in people's homes. There were friends around. People had been taking various drugs, including GHB. And what quite often happened was friends would go out to the bathroom, or someone would stop for coffee or something, come in, and then they would find, you know, one of their contacts unconscious on the floor, not breathing. And then there was a whole issue about, should we call an ambulance, etc., etc. Ambulances were called in all cases, but obviously in these particular cases they didn't get there soon enough and people ended up dying. So it was quite tragic.
Were the police helpful? I mean, I know you tasked them to do it, but did you find working with the police in this instance okay? I mean, was it a reasonable...
In this instance, yes, the police were, because they had not investigated the original murders properly, and arguably, had they dealt with the first murder properly, 3 more young men may not have died. They then found that their professionalism had been severely criticised. So they put a lot of resources into there to try and row back and investigate them fully. Yet they were horrified.
And I'm going to blindside you a wee bit, because we've got a copy of the report here, and it does say official sensitive. But the Met released this. Is there a version that is just too sensitive, or is this what it is? I mean,
well, no, that's really, there's a much better version which I've got here, which doesn't include pages and pages and pages of fairly irrelevant, you know, investigative detail.
Yeah.
The guts of it are most out of the 55, for example, 39 of the victims died in somebody's private home, 6 in saunas, 6 in hotels, a couple in cars, 1 out in the open and 1 in the street. So a lot of these deaths are in people's homes, and I think that's what we thought the tragedy was. These were happening not out on the street as a result of knife crime, but actually in front of people in their homes, and that seemed to make it much more harrowing for the people around them.
If anybody's wondering, there's actually a clock in front of us, so we're going to move on. Leila, you were going to say something.
No, I was going to say, I mean, and then there were recommendations around harm reduction in the report.
Yes.
Can you tell us a bit about them, and sort of what the thinking is?
Well, the issue for policing is that harm reduction is not their primary job.
Yeah.
They're extremely busy answering emergency calls and doing a lot of other things. However, it would aid the police if there was more harm reduction, because attending this sort of incidents, dealing with the aftermath, uses a lot of police time and resources, which in a city like London are very finely stretched already.
Yeah. The
police have an issue, because if they're called to a Chemsex scene and a death from GHB is a illegal drug in the UK, and the police are not allowed to condone the use of illegal substances. So it's a fine tightrope. We work with the police to say the key issue is the health of the victim of the overdose. It's of lesser importance, really, whether there happen to be illegal substances about, and that can be secondary. That's difficult to get over to police officers, but that's a message we try and get to deal with. There are a couple of key things, like a safer saunas project, because some of these deaths have happened in gay saunas, and a related issue of the police trying to disrupt the supply of these drugs, because we've also discovered that drugs gangs and organised crime are targeting gay and bisexual men who have sex with men, at the Chemsex parties, to increase the supply of their drugs and their revenues. Okay. So the police are also involved in that.
Can I just butt in with something here?
No,
we did a straw poll. I mean, it wasn't fantastic piece of research, but we spoke with, we didn't speak to anybody. It was a survey through WhatsApp. 41 people replied to our survey. And the long and short of it was that are gay men less likely to call for an ambulance in an overdose situation? Nearly 90% yes. The bottom line is that gay men are caught between a rock and a hard place. If somebody overdoses, many of them, not all of them, want to do the right thing, but they're fearful that if they phone for an ambulance, the coppers will turn up. And if the coppers turn up, then they are inquisitive beasts and they're going to want to come in and find out. So what happens, there are many, many stories of I mean, a couple I know where guys have been popped into Ubers, literally, and popped outside A&Es and left there. I've known a couple of instances where guys were actually moved into the Guardian while the police arrived. So all sorts of things happen. I mean, I think that gay men are put in an incredibly invidious situation. The police have got a job to do, and certainly some of the work that we do, if you could pass that booklet there, that one there, that's the one. Some of the work that we do is simply to make sure that the gay men understand the law, know their rights on arrest, and understand the implications if and when things should go wrong. And it's quite shocking. Sorry, go on.
Yeah, I mean, you're being a bit hard on yourself there, Patrick. Your organisation has been at the forefront of saying if someone has overdosed and they look in a bad way, call 999 and get an ambulance. That's the message we're trying to get through to people.
Yeah.
Part of my job working with the police is if they have to turn up, which they do for various reasons, you know, look at look after the well-being of the person who's overdosed, not secondary issues like which substances are there. But the message we're trying to get is call 999. Don't hesitate because of you being worried about what the police might or might not do.
We need to segue, and I'm so rotten at that. No, we were talking about the fact there's a whole public health Hep C component to this, because we look at gay men holistically through the work that we do.
Absolutely.
And I really wanted to hear what your thoughts about. I want Hep C clearly needs to have a role in what you're going to say, but there is a public health perspective to this. Which, are you prepared to share that?
Well, in terms of the kind of overdose prevention.
Yes.
I mean, because it's something that we see, I think, across populations, that if people are reluctant to call an ambulance or they're frightened of it, and that might be because there is an actual chance that the police will turn up, or it might be because there's a perception that they might, you know, and either which of those will still impact people's behaviour. And what that means is they might either not call the ambulance or they might just delay a little bit while they kind of decide and people argue over kind of the best next steps. And both of those things are very, very risky for people who need urgent medical attention, you know. So I suppose from a kind of general health perspective, I mean, it's a concern, isn't it, that people need, when there's an emergency situation, people need to really understand that it is all right, and it needs to be all right for someone to call an ambulance.
The reason your messaging has to be clear and crisp is that in those situations, people are not really thinking straight.
Exactly.
Because if everybody's been taking drugs, it's at that point where if their minds were clear, they would know what to do, but they're in a bit of a muddle and they're not quite sure. So trying to get the call 999, get medical assistance immediately, getting that message through clearly is so important.
It really is.
Okay, so there's a health and well-being, sexual health perspective, but we also know that Hep C is an issue, and we've literally, our organisation's just made a short 20-minute promo, Hep C promo, which is just going to go out soon. And I'm curious to know about how the Hep C initiative is progressing in the UK, and are there any specific issues facing gay men in relation to Hep C and Chemsex that you can touch upon?
Summarize,
yes.
In 60 seconds.
60 seconds.
So I suppose the kind of the driver of this, as I don't know how much you'll know about this, but certainly maybe Bob. So there's a global, in 2016, the World Health Assembly passed a resolution even around eliminating viral hepatitis. So that's hepatitis B and C, and one of the reasons that became possible is because Hep C treatment has changed massively over the last 10 years. So it used to be sort of very long, very arduous, very
expensive,
very expensive, lots of side effects, and only kind of 50-50 chance of working. Whereas now it's a sort of 12-week course of treatment. It's tablets.
Oh gosh, so it's much quite serious.
So yeah, so we've kind of gone from a place where Hep C is incredibly difficult to treat to, well, maybe 12 weeks sounds like a difficult thing for other people, but for us it's amazing. And so it kind of brought
about. Is there a vaccine?
No. No, so the viral hepatitis elimination objective around B and C. So Hep B is vaccine preventable, so you can do quite a lot towards elimination with a vaccine. But without a vaccine for hepatitis C, the thing that made the difference is having a treatment that really works and that is doable for people in kind of different contexts, perhaps, who don't necessarily have a kind of easy life and able to do really structured things all day. So in the UK, so we adopted that in the UK, so the kind of elimination objective, and there's been a kind of huge amount of work over the last 5 years with quite an innovative commissioning model, kind of with a pharmaceutical link into actual programming to find and diagnose and treat all of these people who have hepatitis C in England. So it's been a really kind of transformative environment. So
I mean, how does it show up?
Well, exactly. So this is the thing, because like for 20 years you can have no symptoms with Hep C. So it's very much about people understanding that they've been at risk and getting tested proactively. And so because it's linked to blood contact, there are quite specific populations who tend to be affected. So injecting drug users, people who've shared kind of injecting equipment in the past, people who got blood transfusions in the 1970s and 1980s in the UK when there was still Hep C in the blood supply, and MSM populations, which is, you know, a kind of something that's...
Is that the sort of thing that would show up in regular sexual health screening?
Increasingly. So...
because a lot of that goes on, certainly in London now, because it's been computerized. You send you a kit in the post, you take the swabs, take the samples, put it all back, put it in a letterbox, and the results come back. It's incredibly effective, I think.
Yeah, and I think one of the great things that's happened, so I think the latest data I've seen is like there's been a 40% increase in Hep C testing among people, among sexual health services. So sexual health services may not have tested much for Hep C kind of way back when, but now it's becoming much more common. Awareness of the overlap between HIV and Hep C and the co-infection that you see has increased a lot. So we are diagnosing lots of people. We've tested about 50,000 treated over 50,000 people in the last sort of 4 or 5 years. So we're kind of addressing it kind of really, really effectively that way. And we're seeing that for this population.
How does that work? Sorry, Patrick. How does that work in somewhere where maybe the health service isn't quite as developed as it is here? Not that the UK health service is Rolls Royce by any means, in my opinion. I've been in different countries around the place, and there are some extremely good local services. But is that sort of screening available worldwide or not?
I think it's increased a lot. I mean, to be honest, the last time I did global stuff on viral hepatitis was about 10 years ago. So I don't have the most kind of up-to-date information. And I know, you know, certainly our program here, we're really lucky. I mean, we've got obviously we've got kind of NHS treatment, so everything's free. People don't need insurance. You know, when you're thinking about, you know, homeless people or the kind of people that tend to be affected by this, it's really important that stuff is all really open. And so our organisation employ a lot of people who have lived experience of Hep C, who go out and do awareness and testing and engagement and physically support people into and through the treatment process, as well as working with the NHS to make their services more accessible. That's quite an unusual model, and I don't know how far that exists outside of the UK. There are some, you know, there are certainly lots of fantastic examples of work happening internationally. But if you're thinking about, you know, what happens to your average person who's diagnosed in Kenya or something where you really are in a kind of quite resourceful setting, I don't really know what the offer is, but I don't imagine it's quite as easy as we have it here.
It's quite interesting. I mean, we really don't know, but I mean, for example, I happen to know people in Cambodia, if they've diagnosed with HIV, they are given the medication and it's free. You know, it's quite not a perfect health service there, but you know, they don't have to pay for it there. However, I think in Thailand people do have to pay for it, but there are quite a lot of programs who see if you can get the medication, the benefits to the national health are so massive that it's simply worth doing it.
I was at a clinic just a few months ago and had quite a long conversation about Hep C. They brought it up. Do you want to be tested? So I don't think I've got it, but more than happy to be tested. And I wasn't surprised, but I was pleasantly, okay, yeah, fantastic. I go with that.
Yeah.
I'm going to segue to something because one of the things that we do at the Gay Men's Health Collective is provide harm reduction resources. And it kind of links in to what Leila's saying, is that we have a safer Chemsex booklet which goes in our harm reduction packs, and this picture has been around for years, but we love it so much, and that's about what people can do within the context of Chemsex to reduce the chances of getting hepatitis C, and that includes making sure that you wash your douche heads. So combined with the information we've got in the booklet, we've then got cute little flyers, we've got our film coming out, and the Hep C Trust was really kind a month or so ago, went through, reviewed all our information on Hep C, and so that campaign will kick off specifically targeting MSM from early December, just in time for Christmas and Santa. I
think like a better gift I could get for Christmas.
Yes, I know. I'm looking at the clock.
There you go.
I'm wondering where are we going now? You're giggling now. Don't get me giggling.
But right. I mean, maybe it's time for you to talk about some of the challenges about developing Chemsex harm reduction.
Yeah.
Kind of what spurred this session is that, you know, we live in one of the wealthiest countries and the wealthiest cities in the world. We know Chemsex is not going away, but in terms of there being harm reduction messaging or public health messaging, or however you want to call it, our concern is outside clinic and support service doors. We know that once people have a need or have been through some sort of crisis, they're going to find themselves maybe in A&E or in a sexual health service or some other support service, and to some extent they can be tagged at that point and supported. I find it interesting. I think there's a little bit of an imbalance here, that we seem to be cracking on very, very successfully in terms of how we tackle HIV and HIV stigma and testing and treating whatever. We seem to be diving into that with huge amounts of enthusiasm, and it just worries me slightly that for those people that don't end up in some kind of Chemsex support service setting, where are they getting their information around harm reduction? I think it's possible in London, but it surprises me that we're not there.
Do you think it's because it's Chemsex and people's view of it is a bit of a taboo topic?
I think still it's a bit of
drugs. I think it involves possibly multiple people engaging in sexual practices, and is that something that is a bit taboo?
I still think there's a frisson about that, which actually goes back to HIV and AIDS. You know, I think the way that London, and I suspect other cities around the world, but in London, is the way that we're funded. So we tend to work in silos rather than work collaboratively. I think the fact that we don't have a naturally occurring harm reduction public health system for MSM in London, we just don't. These are all achievable, and we've started to have conversations with some of the stakeholders in London around harm reduction. I'm not going to lie to you, the responses have not been great. It's kind of either gone over their head or they've kind of just been very, very polite and had a conversation with us.
Do you get any help from the social messaging app operators? For example, Grindr, which is a social which is a messaging app for gay men, often for hookups. They make a huge amount of money out of it, and it sort of forms the basis of a lot of chemsex parties.
I think that we have tried in the past, whether it's a Grindr or Scruff or some of the others, we have tried. I have to say most of them are not located in the UK. So having what I would call sensible conversations about this and how we might do something is not easy.
I mean, my opinion asked was a loaded question, because we sometimes contact them because people who've ended up being assaulted or raped or even murdered have met, or there is a chain on Grindr, and we find the companies absolutely irresponsible.
Really?
They are more concerned with their bottom line and their profits than breaking what they see as client confidentiality and helping
even for
police.
safeguarding,
even for safeguarding. We have had one useful bit of input from Grindr, for example, on one particularly horrible murder, but apart from that, they are deliberately unhelpful.
I've realised something,
because if they put messages out,
well, I mean,
to would help.
There are messaging that goes out, but it's quite often around testing. You know, it's around HIV testing. I think again, if you're making money, the last thing you want to do is to clutter your airwaves with a lot of public health messaging. And again, how you nuance that, how you target that, what the balance is.
And how clever you are, though, because it doesn't have to be, you know.
No, but you have to get them in
1980s kind of messaging.
You have to get them in the room to have an adult conversation with them, and I think that's really, really tough. And the reason why I'm looking at you rather frantically, both of you, is that apparently we should have been keeping an eye on the messages, and we've completely ignored it.
Okay.
So shall we
have a look at some of the questions?
Shall we have a look at some of them? I can't read a damn thing from here.
First one says, sauna in Manchester has recently successfully obtained an alcohol license, part of their case for provision of safe space for men and the risks of chemsex parties in private residences. What's the role of saunas in harm reduction compared to that of apps such as Grindr?
Oh, interesting.
And the answer is that's absolutely right, because the saunas are a slightly more controlled environment than private homes, because there are staff there and they do know that they should be alert, and they know to call emergency services if they need it.
I've just realised we can stop talking and just do messages now, can't we?
And that, I think, also pins the Met Police's operation of a Safer Saunas project. So I think that's a really key point.
And I think if they are, you know, if they want to work with people, which presumably settings like a sauna is a slight, you know, there might be a bit more impetus if you're concerned about what might happen in your environment, rather than Grindr, which is a bit more able to sort of say that's not our business.
Well, I mean, we did have a sauna project in Greater London. It was working relatively well. It then fell by the wayside. I'm not going to get into the mechanics of it, but the opposite, that we don't have a program in Greater London, and that kind of beggars belief.
It's going to be reinvigorated, because as a result of the DHB death, the Met Police is now suggesting that they reinstate that. There's an interesting question there. Surely a local ambulance protocol can be produced so the police only come for a fatal overdose.
Oh God! Right, here we go. Okay, this is basically this is where actually these two are going to have to tie me down. So somebody overdoses, and the right thing to do is to call an ambulance. Then somebody says, well, don't call for an ambulance because the police will turn up. And then somebody else says, well, we can't do that because somebody might die. So you call for an ambulance, and then what do? You then tidy up. But then if you do that, you run the risk, if a crime's been committed, to conceal evidence. If you don't do anything and the coppers turn up with the ambulance, the party, trust me, is truly over.
We've looked into this, because we want people to call 999 and for an ambulance to come, and we don't really want the police to come unless it's absolutely necessary. Now, the question there said, surely the police should only turn up if there is a fatality. When we've looked into it, it's not quite as simple.
No.
They have to turn up if there are safeguarding issues, if there is any suggestion of underage, if there's a suspicion that there was not consent over
with Stephen Ford,
or if there was a suggestion that another crime had been committed. So it's complex. For example, sexual assault or rape, they should turn up. Or if their officers might be in danger or need to gain entry to the property. So it's a lot more complicated. It's a great question. And I think the protocol should be on the attitude the police take if they do turn up for another thing. We would like them not to start scouring the place for drugs, but deal with the victim and then get on with some other.
I think what a lot of people don't know is that when you phone up 999, it goes through to one big operating thing, one big switchboard, so to speak, and it's depending on the information you provide which service is actually called out. So to think that when you phone 999 and want an ambulance, don't think for one moment the police may or may not be part of that conversation, as indeed the emergency service and the fire brigade might be. So and it's really, really tricky, because if somebody's overdosed and somebody on the phone says, well, what do you think they've taken? What do you say? Well, I'm sorry, but putting my Mr. Cynical hat on for a moment, if you say, well, I think they've overdosed some GHB, do you not think for one moment that PC's plods ears are not going to pick up?
Lee Collingham, who's asked that question.
Have they?
I've just thought again.
Well, I'm really bad at this.
Surely a local ambulance protocol can be produced. And I'm thinking, yes, probably it could. The Met's very big and complicated. So it may well be a brilliant idea to see if we can work with the ambulance service so that something is flagged if it's a certain type of overdose.
About 10 years ago, I did look at the guidance for ambulance services, and I noticed there was very specifically a section around that ambulance staff were there to look after the health and well-being of individuals, and that it wasn't really their job to be tattletaling to the police, for want of a better word.
Yeah, absolutely.
I've looked at the more recent set of draft, which last year paid a princely sum of 50 quid for a copy online, and all that had gone now. So you're absolutely right, Bob. Yes, there needs to be something. I think there was something in place. There was something quite fledgling that's gone. We've only got now 28 minutes, and we need to look at these questions.
Yeah. Are you high? There's no more.
No more questions.
Oh, no more questions. Oh, we have that. Awful.
Okay.
We've done all the questions.
Where were we then?
I have no idea. No idea what we're talking about now. Oh yes, can I talk about my separate hookup booklet? Only because it kind of taps into everything.
By all means.
No, this is not a plug at all.
No.
Because most of you may well be halfway around the world, so we'll send you one if we can. No, quite by accident, yes, we produced a book with nothing on it. We pulled together a booklet which has just got 12 tips, and it's about that if you're going out and hooking up, and meeting people. I would argue that 20, 30 years ago, we were slightly better at passing on.
Sorry to interrupt, but Lee there is texting again, and he says it's a big, the huge stigma around chemsex. Investigations, he says, can take place after. Surely saving a life has to be paramount.
Yes.
We couldn't agree more, and I'll write that one down. And yeah, fantastic. I think that's going to spur us on to
do something. So all I'm saying is that 20, 30 years ago, and again, I'm an older gay man, so therefore I remember this, and I'm not younger, so I'm not going to know completely what's going on today. But certainly in terms of kind of safety and information and who was around on the scene, we kind of passed passed information around ourselves. And when you pick somebody up, you quite often say to your friends, this is so and so, and you'd quite often exchange phone numbers. You'd write down on a piece of paper. We don't do that anymore. And I just feel that now in 2021, we have a generation that are potentially less informed about what they need to do to protect themselves. And very, very quickly, if a hookup doesn't feel right, then I know it's difficult, but don't think with your cock. Think twice before agreeing to meet up.
Don't what?
Think with your cock, penis. That's all.
Oh, right.
Remember? Yes.
Yeah, okay. Yeah.
Let somebody know where you're going, even if it's a WhatsApp message. I mean, it's that simple. Have an exit plan. I mean, have 20 quid note. We're not always in guard. A 20 quid note in your trainer.
Sock.
We talk about consent. If you use drugs, think very carefully about what it is you accept from people you don't know. I mean, there's just, all we did was put down 12 tips, and it's gone like hotcakes. And I think people are just appreciative that we've kind of gone back to basics as a reminder, saying, well, frankly, whether you're younger or older, it's more complicated than it was than perhaps 20, 30 years ago. And that if you are meeting somebody on an app, you need to be mindful of things to make sure that you are as safe as you possibly can be, whilst having, at the same time, having a good
interesting
time.
you say that. You think perhaps the younger generation are
I know,
less
that's awfully patronising.
Well, no, it's not patronising. Is it true? But you know, on the one hand, there are apps and the websites. Surely there's a wealth of information on harm reduction online that young people probably access, YouTube, TikTok, and all the rest of it. Do you know what those are, Patrick?
I know the information exists.
Have you heard of TikTok?
Yes, no, of course I have. We have an account.
Have?
Yes.
Yeah.
Can't be asked to use it, but we've got one account.
A lot of young people use it.
No, no.
So, no,
yeah,
being serious for a minute.
Yeah.
There are those channels. I mean, my sort of teenage nephews, you know, can sit and study their physics and have a streaming TikTok stream and a YouTube stream going on at the same stream. They seem to absorb information from all sources. So is not the potential for them to be more informed?
And
yes.
I think there are ways, aren't there? Because, you know, there are very clever ways that you can actually target people and try and get the right information to the right people using social media. So there probably are lots of opportunities, which I'm sure people are capitalizing on already, to try and get that information. One of the things that we were talking about in relation to Hep C, but also lots of other things in Chemsex more generally, is that if a lot of the harm reduction information is coming through specialist services, you have to be quite far down your road into getting involved in whatever it is before you pitch it up at a specialist service. And so how do you reach those people at the beginning so they know to look for some harm reduction information? I suppose it's that bit, isn't it, that period where you're not really sure that you need help or that you need information.
And let's be honest, when you're younger and feeling invincible and feeling you have all that, that power and choice, and you're having fun, why do you want anybody telling you need this? No, of course I don't. I can manage. I've got my mates. You know, I can do it.
There's a couple of interesting things. There's some younger people who I know do take G and T. I think that's crystal, isn't it? You know, they are not completely irresponsible about how they use it. Like, they're careful about self-measuring, self-administrating, terms I don't really know about, but they are. I think the tragedy, coming back to the start with the Stephen Port things, the victims there were not really aware of drugs at all. And I think for that reason, they got lured into this situation where they were given fatal overdoses. And I think that's probably another danger. So it's possibly more information for people who are in the scene, as it were.
It's a really difficult thing to gauge, but I think the argument, I would say there is an argument, at least, having some sort of harm reduction messaging. If it's not harm reduction, public health messaging, well-being information, that basically just helps people tick the boxes which say, I'm going to go out and have a fantastic time, but as far as risks are concerned, I've addressed those as far as I think I reasonably can.
And I'm going to this informed.
And going there informed.
What I'm doing.
And not only that, through our work, if something goes wrong, I know where I can go and what I need to do.
Exactly.
And that comes back to kind of Bob's stuff, is that, you know, that if you are felt up by the coppers, you know what to do, you know what your rights are on arrest, you know where you can get help.
Yeah.
Do we have any more messages?
We don't have any. We've got lots of.
There's some
comments.
Good points. Yeah, there's some great comments. And there was one about kind of, you know, the opportunities to use hepatitis C for wider harm reduction.
We've talked about this, haven't we?
And I think it's a really good point, you know, and particularly in some of the sexual health services in London and elsewhere, you know, that kind of I suppose across the board, that kind of that integration of services. So as people are seeking help around hepatitis C, or as that kind of risk is recognised, there is a lot of opportunity. You've got that person there. You know, what else can we do? And I suppose for Hep C at the moment, there's a bit more of a focus. There's a bit more awareness, a bit more energy around it, I suppose. So maybe we're reaching people that perhaps aren't normally reached by health systems. And so it's a kind of, there's been some great work in London and elsewhere around sort of integrating HIV and hepatitis C testing. So if someone's being tested for hep C, we can also test them for HIV, but also recognising these are the risks and using that chance to deliver harm reduction information, to deliver information and education around different things. And I suppose from a kind of, general public health perspective, what we were talking about before, there is this idea of kind of making every contact count, which is quite well established in some parts of health and perhaps not, and social care. There's quite a lot in housing and those sorts of things, but maybe with the police and there are a lot of different agencies who come into contact with people at different difficult times in their lives, and thinking about how we can do that in a manageable way without expecting them to do all the work, but particularly I suppose the blue light services and the ambulance protocol being again kind of example of that. Capitalizing on those opportunities and making sure we're really doing it properly is really important, isn't it?
I think the ambulance protocol, Lee's message back again. I think he might be from Manchester, saying he's going to look at his own ambulance service to see if there's a protocol. I think we did look in London to see if they automatically call the police, and they don't. I mean, I think what came across was the ambulance service and the Met 999 sending cars was so busy that really they hardly had time to think about, shall we, send the police here. It's only if it was essential. It wasn't a fog. And, ambulance services control rooms and 999 police control rooms are busy places, especially on Friday, Saturday and Sunday nights.
Is it worth my mentioning the pilot we've been running in A&E?
Yes,
definitely.
Because that's where you're doing some work in A&Es yourself.
In future.
What is the pilot you're running in A&E?
It was really quite simple. I mean, it sounds very, very grand, but we pulled together all our Safer Chemsex resources, which is literally about 5 things. We put them in a black envelope, and then we sent them off to an A&E.
A&E being?
An accident and emergency department. And we know that in one A&E, you're looking between 5 and 10 admissions on a weekly basis. It goes up and down, but you're looking between 5 and 10 for GHB overdose.
GHB overdose.
And also other drugs. But in terms of what they're now quaintly called, and rather disparaging, as frequent flyers, quite often they'll have return visits, but they're coming to A&E, they will have overdosed. Some of them, a few of them, will probably be admitted for further treatment, detox. Some might go off for detox. But at the end of the day, there does appear to be a conveyor belt where coming people are going to A&E.
Lots of different conditions. There are particular groups of people.
We had this pack, and what we've discovered with this pack, and this is what's getting exciting, is that staff have said, well, thankfully, we can actually give somebody something to take away with them. Secondly, resources are well written in the sense that they helped us think about the questions we need to ask. And thirdly, it's a better use of our time in A&E. So it's a better outcome for the patient, better outcome for the staff. And we've piloted this in one A&E in London. And even in the last couple of weeks, interest in terms of rolling this out elsewhere has stepped up a gear. And I think, that's a very, I'd like to think that's quite an intelligent pinch point that we're addressing. And it's a relatively cost-effective tool with which to, where everybody wins.
It's written in a sort of accessible way, isn't it? Riskometer, for example.
Yes, I know
what's
that.
High risk, what's low risk. But yeah, it's great. I would.
And for me, it's that thing of, I've done lots of work on different health topics where people don't have that conversation because they feel a bit nervous, so it's not that they don't want to talk to somebody about something, but they healthcare workers I'm thinking about mainly, but they don't feel that confident, or they don't feel like they have the right thing. And just having something like that to be able to say, oh, I've got this thing, why don't you have a look, how about this? I mean, that is, that can just open up a discussion in so much of an easier way.
The first tip we have in our booklet, which the staff said is most handy, the first tip is around PrEP, U equals U, checkups and sexual health. And they say that oddly enough, the first tip is just a great way to say, look at this booklet, it's got a few ideas.
And I think that's useful, what you call the bust booklet. Which
rights on arrest.
If the police turn up, if someone's read that, you know, when they're not already taking drugs or they're quite sort of able to absorb the information, that's there when they're thinking, shouldn't I call an ambulance? They know they are not just subject to the whim of whatever policeman turns up at the door. They have rights, and there are protocols, and there are people they can contact. I
have to give a shout out to Release, because while this is our booklet that we've printed twice now, Release, who I know many of you will know, they wrote a booklet, and we asked if we could use their text, which they kindly gave us permission for. So that's what we have in this booklet. So the booklet is ours, but the text is Release's. So thank you, Release. We love you.
If you turn to that page on your booklet and that QR code, if you scan that, that'll take you to a website.
Oh God, yes. Yeah, I keep forgetting about this.
Yeah.
Just about all the resources we do has got a QR code. And we have a health and wellbeing website called menrus.co.uk, like Toys R Us, Men R Us. And the whole point is that this basically is a conversation starter, and particularly around the stuff we did on hepatitis C. Yeah. This is the flyer that's now in the packs. Well, there's the damn great big QR code. Now, if you go there, you will be able to go to the website, which will give you much more information, and where you can get help and support. And we must thank Hep C Trust for that, for helping us bring that up to date.
You're very welcome.
And when it comes to some of the more criminal justice related stuff and hate crime and everything, you know, we will defer to people like Bob.
Yeah, sure.
We've got 15 minutes left.
Here?
Oh yes, I got. Any other questions? Yes, I know you can.
Oh, there is one. I'll read it out. Judith says, I used to discuss this talking to people about 999 in the case of heroin overdose. Yeah, exactly. I suggested they call 999 someone unconscious. They may have taken something, I don't know what.
Yeah.
Don't give them more information on the phone. Just get the ambulance out and tell the paramedics when they're right. Yes, that's absolutely right. And I think
how nuance your language in your wording.
Yeah, but I think there's also an overdose protocol for heroin, isn't there? Is. I don't know exactly what it is, but there is a special ambulance protocol if people have overdosed on heroin, which means they prioritise getting to the person and dealing with their health needs.
I love we're getting comments, but I can't read any of it.
Well, I just read it out to you, but that's a great suggestion, Judith.
And it's that thing, you know, if you want people to act quickly, if you give them a kind of a thing that they know exactly what to do in that situation, and having that phrase is like, someone's unconscious, get an ambulance.
Get the paramedics there. When the paramedics do get there, you do need to take a leap of faith, because you do need to tell them what you think they've taken so they can treat them properly. But with goodwill and sensible policing and ambulance services, they'll concentrate on the health needs and not bother about the, you know, not really be worried about the amount, the drug that was taken. The amount of heroin or class A drugs in that location will be minor. The key really is to target the people who are supplying it.
And if people want to do it, but if people want to do that with confidence, they need to know their rights on arrest. They need to know when questioned. They need to know that stuff. And it's almost kind of the last thing you think you want to know about when you're going off to have a good time.
You've got another comment from Howard here. The theme within drug overdose death is people using alone. This doesn't apply with Chemsex, so there's an important opportunity for harm reduction and safer drug use messaging, educating people so that they can look after each other.
It's funny.
I think Lee's responded to that and said he agrees, and Chemsex is often multiple folk about basic ABC airway, breathing, circulation training for clients.
Yeah.
Yes.
I don't know if people do that.
Yes. What did I know? There was something here. No, oddly enough, I think I can say this. God, I hope I'm not going to get shot for this. No, we've been having a conversation with Exchange Supplies, who I believe is supporting and sponsoring this event. Yay, go Ace, go ES. And they were talking about an individual that was, I think, you know, could probably do with some safer injecting advice. but we had to go through the basics as whether maybe the drug that he was taking was shit, or whether he was or wasn't using a filter. And one of the things that we've come across is particularly guys that are shooting up by themselves, don't know whether they should or shouldn't be using a tourniquet, and whether their targeting is any good when they're trying to hit the vein. So we're having that conversation now and going back to him saying, well, let's look at all these things as well. So no, we get calls like this quite often.
Is there something we can add to our thing? I mean, it was
about what?
Again, Lee's point about, in addition to all the other stuff about airways, keeping airways clear while the paramedics arrive. Yeah, you do.
I think no.
Do we?
I'll tell you why I don't do it and why we should. And I think one of the things, I think we've shied away, and be brutally honest, we've shied away from giving advice that is in effect instructing people or advising people to do X, Y, and Z. Now, we know it will save a life, but if it all goes tits up and somebody dies, then you run the risk of somebody coming back to us and saying,
it's about that.
As a balance.
But there is a balance.
The main message is call 999. This isn't instead of calling 999. It's while you're waiting for someone to arrive, you might be able to just do something.
I think even on the back of this session, I think I'm inspired now. I think we need to go. As we knew, we need to go back and look at ABC. Thank you. Who's that? Lee. Thank you. Lee. We love you a lot.
There was a report out from the government commission. Dame Carol Black was
we were talking about. I've just sent her a letter.
Did you?
A thank you letter.
Marvellous, yeah. So she's a medic. Black. She's done a report around drug prevention and drug harm prevention.
Not like,
and
it's not like Judi Dench, not an actress.
No, she's not an actress. She's a medic of something, some prescription.
And she's got a dameship.
She's got a dameship, so she must be eminent. Yeah. But yeah, so she's done a really comprehensive report around drug use in the UK, and one of the things that comes up there is, we've got the kind of there are gaps around harm reduction anyway. Plus COVID bringing in all sorts of challenges there, but then harm reduction, needle exchange, those sorts of things for communities or for populations who don't really identify with the typical injecting population, I suppose. So particularly thinking about MSM involved in chemsex, people using steroids, performance and imaging enhancing drugs, that sort of specialist harm reduction, access to equipment, access to education, things around,
but how do you deliver that?
Where's that?
How do you deliver that within what I would call the stance that central government takes, which the Home Office takes? It is I've always taught. I remember it was Nick Wilson at Exchange Supplies always telling me, always said, harm reduction is always the backseat to treatment at the moment. That's just the way it's been for the last 10, 15 years. And I know that many of the conversations which are going to be taking place through the Constellation Conference are looking at that and the disparity. Sure. But unless we get harm reduction, unless there is the tanker gets changed in London, the valuable harm reduction that you're talking about, it always worries me that it comes second or third place.
Lee's raised.
Oh God, hello Lee.
No, it's just.
No, we should invite Lee onto the panel.
He's as a fourth person. He said the Good Samaritan law protects intervening in a death.
Yes,
no, I'm not quite sure about that. So that's if people are trying to do something.
And then
but
I don't know if that's if your training
wrong.
Is bad, then isn't that? I don't know.
Yeah, we shouldn't really be giving too much medical training, but airways clear, call 999 and certain
because they do it with fast for strokes and things like that, so there must be
absolutely.
a kind of.
I think without any shadow of a doubt, and you spurred us. We need to get. We're going to get onto this. Thank you. We've only got 7 minutes left, and I think what's the similar? It's people just saying nice things ish and just commenting
that's
on
right.
This is a very responsive.
Naomi, I love the booklet. No, thank you for the booklet.
I mean, just.
Can we wrap up now? How do we wrap up?
We were going to wrap up talking about the question.
Oh yes.
Coming round full circle, this last bit of discussion about these chemsex. Where's that police report you had?
Your police report.
That one.
That thing is, I didn't labour it to start with, but the bleakness of reviewing these cases was really, really awful. It was people sometimes alone in hotel rooms. Sometimes with friends, but the worst bits were where friends suddenly found someone they know quite well, unresponsive, on the floor, in their own living room, in their home, and not being quite together mentally at the time, faced with that, where the person might die, and unfortunately quite often did die there in front of them. It's a bleak, horrible position to be in.
Yeah.
And anything we can do from these suggestions here, the protocols and the rest of it, to alleviate that or stopping it, it is a thing well worth doing. Don't want to make it sound too bleak, but it was horrible. We had some hardened police officers on the panel, and we literally had to stop for breaks.
I remember you talking about it. I remember you being, well, you were just generally distressed. It was awful.
Yes, it is. So anything we can do, really.
We've got 5 minutes, so let's go back. Ta-da! Chemsex harm reduction in Greater London, the perfect storm. I'm not going to lie to you. This was my title, and I'm curious to know whether there is any merit in this. And again, I'd like you two to finish off, but my sense is that we need some kind of harm reduction, public health well-being messaging around safer drug use, harm reduction with Chemsex, as we put in. That would be helpful in terms of hopefully reducing the number of people that actually end up knocking on doors or being admitted to hospital in the first place. We don't have that, and it worries me that in the present climate, we're coming out of a pandemic, God willing, with the cuts and everything, with the stand on the government and everything. It worries me that this idea of harm reduction in London around Chemsex is struggling to get traction, and I kind of understand why. But if we don't do something about it, I think we have a perfect storm.
You're in the medical, but isn't it a bit like social care and the NHS? If you spend money on social care, in this case, we spend money on harm reduction, you put less stress on the rest of the system. So if we do the harm reduction, which ought to be relatively cost effective, we put less stress on the police and less stress on the ambulance service. At the moment, they're stressed beyond breaking point, certainly the ambulance service. So it shouldn't be just, it's all going to cost money, resources are difficult. It's a small amount of money which should save a lot down the line.
Yeah,
how do you get
see that with
message over?
Prevention and health across the board. Preventing a disease is always vastly more cost effective than treating it. But that thing of when you have two people in front of you and one of them might get cancer in 5 years and one of them has it now, who do you give the money to? That's when it becomes the decision is quite different, isn't it? It's a lot easier to make that business case for giving money to the NHS rather than to something that's preventing somebody goes to the NHS later, particularly if they're a population that some people don't have great sympathy with, and it's awful, but it's a really difficult balance, isn't it? And it is something that we need to look at again. I mean, we've certainly got it with Hep C. Preventing Hep C is the only thing. If we want to get to elimination and we want to maintain elimination, we need to prevent those cases. We've
got a message there from Howard. Yes, you're right. Recovery is UK government policy, but harm reduction always comes first. You can't engage someone in recovery if they're dead. He says absolutely right.
Thank you, Howard.
And if you can engage them, you can do not making massive assumptions of people's needs, but you can address mental health if it's there. You can address whatever else there's there. If you're doing something proactive around keeping people healthy and early intervention and all that kind of stuff, then you can prevent the Hep C and the HIV and the overdose and whatever, and work really constructively with people. And I suppose it's that bit, isn't it, that's so important if we want to really change people's outcomes on a big scale.
Well, we've got 2 minutes.
Well, let me just say before we finish, I've sat here this morning. I'm absolutely inspired. I'm going to go and crack the whip with some of these.
Tell them how much you doubted this format. Go on, tell them how much you doubted
another one of my roles in the Met is monitoring the 999 call centre response times and that linking with them. I'm going to go and go and raise some issues. The response is fantastic.
What about
watching. Don't put pressure on me now.
All right, then I'll finish. Look, I have to say we hadn't thought through the messaging. So If any of you have questions or would like to contact us, it's admin@gmhc.co.uk, admin@gmhc.co.uk. Believe it or not, we answer all the emails. We love to hear from people. If we possibly can, we'll send you single copies of resources, but postage is expensive. We will try. So I think we've kind of wrapped it up. Did you want to say anything now? Or do I feel like
no? I feel like I've.
You're done. You're spent.
Yeah.
You're spent. Are you done?
Yeah, I'm done, except you don't need to send resources, send them a series of QR codes.
Yes. And just the other thing, oh, look, someone's been really clever. Thank you, Constellation team. The other thing is menarus.co.uk, MENRUS, like Toys R Us.co.uk. That's our health and wellbeing website. And very quickly, a huge shout out to all the volunteers and organizations that support us, because we're volunteer led and run. It's organizations like Exchange Supplies, the Hep C Trust, the Advisory Group, Release, Harm Reduction International, just a ton of people. So look, I hope you've enjoyed this slightly different.
We have.
And thank you very, very much indeed for watching, and enjoy the rest of the conference.
And thanks for the comments.
Yes,
and thank you for the comments. Yes,
engaged,
thank you.
It's hard, isn't it, presenting to a...
Well, clearly, if you can't read them. Listen, we're going to go. Can somebody at the other end cut us off now, please? Thank you.
Have a lovely
yes, have a lovely rest
conference.
conference.
Lovely to see you.
Thank you.
Take care.
Bye-bye.